We use this ever since for patients, and especially young patients. For example, if they have a compression fracture, that is the best indication. Compression fracture, TH12, L1 compression fracture, because that is where the micturition center is, and any peripheral paralysis of the bladder starts there. And any patients that, male or female, that have an extensive lymphadenectomy, the same thing, they may develop a acontractile bladder, and then they may be candidates. We have published since that. I started with the Lancet publication with a surgical indication in the Lancet, was also something fairly new at that time. And then this is what it is about. The special thing about it is that if the bladder becomes acontractile, don't put a muscle onto the bladder, because the muscle, the striated muscle, it will contract. And if you suture it to the bladder, it will just distend that part of the bladder. It will end up as a little cap on top of the bladder. So what you have to do is you have to really suture it to the pelvic facial structures within the pelvis. That is one thing. The other one is, and that is where the expertise of Milomir Ninkovic comes in. It has to be a functional muscle transplant. He taught me that, and I took me some time, a couple of other beers to understand that. But that is, if the nerve stays, if the nerve is connected, coapted to another motor nerve, not only the muscle will be viable, the muscle will do what the donor nerve, so to say, is doing. If your brain says, I want to contract my abdominal muscles, and you hook to that nerve at the abdominal muscle and latissimus dorsi muscle to that, then contracting your muscle, then of the abdomen will also trigger the contraction of the latissimus dorsi muscle that is connected. Now that is the schematic of that video. Yeah, you can see you can do a Pfannenstiel. This is not perfect. Either Pfannenstiel or midline dorsal incision. You go in extraperitoneally. You free up the bladder, and then the bladder will stay like that. I'll tell you more. I don't see it here. And then you dissect the latissimus dorsi here. Yeah. I'll show you why it's latissimus dorsi. You connect it not only to the vessels. And the vessels you connect it to are the inferior epigastric vessels. They are there. They are good, allow a good perfusion. But the important thing is connected to a motor nerve. And Miele is excellent, as we know. Yeah, it's an excellent surgeon. You need a good plastic surgeon because this is an elective surgery, and nothing should happen because the patient does not have cancer. He has something that should improve his quality of life. And so there must be a good, I would say 100% 100% success. This is the latissimus dorsi vessels, dorsal artery and vein, and the nerve. And that is what you only do that once you have freed the bladder. So the muscle should not be without vascularization more than 60 minutes. That's what Miele came up with. And then once you do it, you connect it, the muscle is reperfused, and then the muscle is connected to the pelvic facial structures in the pelvis, not the bladder. And then that's it. And so show you what is important. The functioning is dependent on the innervation, of course, the vascularization as well. It's not a pedicle flap. You cannot do a pedicle flap from the latissimus to the bladder. Too far. You can do it for the breast cancer patients when you build up a myocutaneous flap from the latissimus dorsi. That would be a pedicled flap, and if you leave the nerve, then it's a neurovascular supply, but that is not possible. And the free flap is what is done here, free flap and functioning. That is free plus the nerve, and the nerve is then coapted. It's for the atonic or hypertonic bladder, and it is important that there is an intact urinary sphincter. You'll see that in a minute. Etiology, anything that is a truly atonic, paralyzed, whatever you call it, or hypertonic bladder. Most of our indications in our patients were spinal cord injury. Most of them, again, were at the level of TH12L1 or lower. But there is some congenital malformation, myelomeningocele, for example. We had those patients. The ones I did or we did, I also had to increase the volume of the bladder by a TRUSA myomectomy. You can do that. Any pelvic surgery with extensive lymphadenectomy, pelvic trauma, and we had some patients that had an overdistension. A very tragic case was a young lady. She wanted to have a breast reduction. She was like 20, 21. Breast reduction. She got that breast reduction, and postoperatively she did not have a catheter. She couldn't formulate herself, and she went into urinary retention postoperatively, and she had a complete long time overdistension, and she had reduced nice breasts but a non-functioning bladder. And for example, that was one of the indications. So. The muscle selection is, there are several things you have to deal with. I mean, there are several muscles candidates, so to say. But the problem is either the bulk of the muscle is not good enough, or the vascularization has, like the gracilis has different vascularizations, or the rectus muscle, for example. Why not rectus muscle? Well, the rectus muscle here, if you want to get it down to the bladder, you have to dissect most of the innervations. And that is, you'll see in a minute why that doesn't work. And the latissimus dorsi is of all the best one because if it is the biggest surface, so to say. It's a muscle that has a contraction that goes mostly bilateral. And it has, again, one major nerve, one major vascularization. You can see here that's a different. And the strap muscle has a very long contraction range, whereas the bipennate muscle, for example, is more bidirectional in their contraction, which is also important thing. That is why the rectus muscle doesn't really work. Again, this is something, actually we did that on a cadaver, actually to see whether we can use it for the sphincter as well. Because there was one thought, why not use it for urinary sphincter? Well, the problem here is you can get a piece of that muscle with two nerves for the sphincter, but then the problem is how to find the right part of the pudendal. But that's a different thing. Anyhow, what is important is you have in the rectus muscle you have the inferior artery and vein, inferior epigastric artery and vein, and you have one or two motor nerves which you could use for connecting the latissimus dorsi, which again by size, by its pedicle, by its minimal morbidity. The important thing is, which we know, and Emilia knows very well from plastic surgery, you can get the, you can use the latissimus dorsi, and the patient still will not feel it under normal circumstances. It's the wheelchair patients maybe, but even the wheelchair patients don't have a problem of using it for their wheelchair. Even climbing, only if you're doing competitive sports you may think that there is a problem. And the configuration which we talked about, this is actually the experimental studies which we did in Hungary. a lot of stories, and that is eventually why we were able then to use it in patients based on these studies and the publications which we did in the 90s. And you can see here what is on the this is the opening of the suprapubic catheter of a constantly atonic bladder, which was only managed with a suprapubic catheter. You cut the inferior epigastric artery and vein. You connect it to the latissimus dorsi, thoracodorsal vein and nerve, and you use the motor nerve, one or two, depending on the size of the nerve, the lowermost nerves that go to the rectus muscle. Mine you won't see. If it's the real Arnold Schwarzenegger type, you would see it. Yeah? It has different bulks in between the tendons, and there are nerves, 8 nerves altogether. If you use one or two of the lower nerves, you will neither see it nor you will the patient will feel it. And then that is how it looks intraoperatively. Left is how we dissected it on a cadaver. On the right, you can see here these motor nerves. Take 2 if it's small, take 1 if it's only a larger one. And then here is the main surgical steps. Here is the latissimus dorsi, marked usually with sutures, because once you cut it, it will contract by 1/3 of its size. And so then you know when you reimplant it with that how much tension you have to give. And then these are the pelvifacial areas or structures where you connect it to. Don't connect it to the bladder. Don't connect it really to the levator muscle, because here it will always have a distraction and not really work that well. And from the sacroiliac ligaments here on that side, deep down or on the inner side of the tuber ossis ischii. I mean, you're with your hands almost on the table, but within the patient. And then on the inside, that is where you start, and then you go all the way around with your sutures. And then the important thing is, once you have connected the vessels and you have coapted the nerve, then the muscle is not only viable, but it is also functional. Not right away, but that is will take some time. Again, here the area where the fixation of the latissimus dorsi is done in the pelvis. And you can see here we did the first long-term results were more than 18 months, which is important. First of all, you have to wait. You should wait 2 years after a trauma, for example, so that you see that the patient, that the muscle, the blood is not recovering, and then you have to wait for some time. And you can see here that the patients are really doing well with the initial capacity, and then with the residual. Again, it is not 100%. Look at here. Yeah, I always say when I consent the patient, it's going to be around 80%, 80 of a success. Especially the idiopathic bladder hypertonicity is the one where we have the biggest problems, because there may also be a detrusor sphincter dysynergia, and then the sphincter doesn't open up, because then you can put a lot of pressure on the bladder, but if the sphincter doesn't open up, it won't work. That is here. You can see here we did a dynamic CT, and you can see here how from the right side the muscle really contracts the bladder and empties the bladder after a year. It was done a year or something later in a patient. And that is the picture which we did in a female patients who had to undergo gynecologic surgery, and 3 years later I was asked to be part of that surgery because they didn't want to ruin anything, and we were allowed to take a biopsy. And you can see here that after 3 years the muscle stays viable, but there are still there is some fat around that, because that muscle, when it is a latissimus, it has to do much more work, and it gets, of course, it atrophies to a certain point, because the contraction of the bladder, the muscle doesn't need all its strength, but it's still after 3 years, you can see it's not only viable, but it is also functioning. And then you see here, yeah, and this is how we played around a little bit during the surgery. Yeah, you see, you stimulate the nerve, and you can see how the muscle around the bladder here really is contracting, and you can see here the anastomosis and the coaptation of this, and that's, for example, a case of a patient with a chronic bladder dilatation. This one was not acute, but chronic. But again, the same thing. You see that the muscle is harvested. Yeah, the muscle is harvested here. It's what the muscle looks like here when it's on the field, and after it has been put into the thing, all that is latissimus dorsal. Here you see the connection, and here you see the coaptation of the nerve. And yeah, that's we have been doing some a multi-center study some time ago, and we went to Maastricht, and we went to Mumbai, and we went also to Malmö and to other places, to Houston, and did some either surgery or some lectures and courses there. And that is, most of them are actually trauma patients with a TH12L1. That is the area where a lot of compression fractures, I didn't know that either, happen, when patients fall down, and that happens in young, for example, construction workers and so on. And the time, the important thing is, I'll just go through it because of the time. The important thing is that it's not done too early. You have to be sure, you have to make sure in order to allow the possibility of a spontaneous reconstruction of the bladder function, that you wait at least 2 years, maybe 1 year if it's been a long time, but definitely not below 1 year. And that is, in our case, it was on average 5.5 years in that study that the patients had been on intermittent catheterization, and that before that, IVP, you have to make sure that the upper tract is okay. Urodynamic assessment, of course, you have to make sure also by urodynamics for documentation that the patient has a paralyzed acontractile bladder. And then I usually scope the patient. I scope because I want to see the sphincter spiel. Yeah, that is important. Because if you can't see the sphincter spiel, then the dysynergia and the non-functioning sphincter that may be spastic may ruin your outcome. And that is especially in the iatrogenic, in the idiopathic acontractility. And then I lock the myography of the rectus muscle. Must not be, you can, the patient feels it, and if you can see how there is a contraction, and if there is no bulging of the lower abdomen, which sometimes you would see in that patients, if that is not existent, then you don't have to do that. And afterwards, post-operatively, I usually wait. In children, it's much faster. The youngest one which we have done was 9 years. And of course, they are, after 2 months, there is already a regeneration of the nerve, of the motor nerve. In the adult, it takes longer, and I would say anybody beyond 65, 70, I don't want to be unfair, but they have a much, much slower regeneration of the nerve. And by the time the nerve regenerates, the muscle may be already damaged too much so that it wouldn't work ideally. So that is the upper limit, which I would suggest, but that is also individual, like in oncology. Usually I put the bladder on drainage for 3 months, 6 weeks catheterization, so it can heal in, another 6 weeks with intermittent catheterization, if the patient has done that before, and then the first attempted voiding after 3 months. That is not as difficult, because what do you do if you cannot void? You just contract your abdomen. And that's the Valsalva maneuver. And that's exactly what you need. That is the trigger of how you get to work that muscle. And that is, these are the results. There are several others in the literature. I'm saying it's not 100%. Yeah? but especially the idiopathic ones, that's where we have a problem. But I usually consent, and that is consenting on our own data is 80% success rate. And what I do is in male patients, in elderly male patients, I usually, if there is any indication, I usually do a transurethral resection of the prostate, because that inferior vesicle obstruction should be excluded unless it's a very young patient. And that is the results. That is, we've done urodynamics, we've done all kinds of, looked at the complications. Of course, you know, it's a major surgery, but on the other hand, it's a surgery, elective surgery, so there should not be any loss of the graft, any loss of the latissimus dorsi. Mila and I, in all the cases we have done together, we have done quite a lot of those that have been done, and we have not lost a single latissimus dorsi flap. And that is, you know, you need to do that. Even if we had lost it, it's not like in heart transplantation where the heart is taken out and what happens if the new one doesn't work. Here, the bladder stays. And if it doesn't work, it shouldn't be, but then it is something that will not change the patient's life. And that is something which was so important for us. So these were the results which we had done, put together in our thing. There are other publications, other data, more data which we have done together, and that is those that have contributed to that study, but mainly Mila and I. We are apart on the operating table. We are very good buddies on the outside as well, at least for my part. I hope Mila says the same. But you need to have, if you do that, and if you're not a good plastic surgeon trained urologist, then you need to have somebody whom you understand very well. You know? You're working at the same time on the table, one here, and then the plastic surgeon switches here, and you know the size and any other things. You know, if he's right-handed, left-handed, that also plays a role. That has to be talked and discussed, and you need to have somebody whom you understand very well with. Thank you very much for your attention.